start in a minute. So I guess everybody is excited to start. But before anything else, I would just like to welcome back our participants, for this is our last day. Can't believe how fast time flies, right? It's been a wonderful experience so far, yeah? Agree? All right, cool. All right, so before we start, I would just like to remind everyone to please turn your phones into silent mode so that we would not be distracting our whole experience, right? And then today we got a very good set of topics for everyone. So first and foremost, my name is Rod. I will be the chair for this morning session. And I'm with my co-moderator as well, Professor Monica, and I will introduce all of our speakers just later. So right before the start, I would just like to recognize the important contribution of our community members and community workers, because they've been in this whole response with us. Without the community, we would not be going anywhere. And that's why we are having this conversation right now, right? So right before we start, I would just like to hear everyone to say this important quote with me, with us. Can you say it out loud, please? Yes? 1, 2, and 3.
Don't walk away.
Oh, no. Sorry. That's the lyrics of a song. Sorry. This one. All right. Can I say it out loud?
Nothing about us without us.
Yeah. Nothing without us. Nothing about us without us is a campaign that emphasizes the importance of involving people affected with and also living with HIV, right? And the key populations, involving them in programs development and also policy making. Key populations possess first-hand experience and valuable insights on living with or being affected with HIV. Oh, not this. Okay, now, first and foremost, we would like to define what community is. Community is a group sharing a common identity. It is defined by a variety of factors, including geography, ethnicity, religion, or shared interests and experience. Do we need to have what they have for us to be able to understand what they're going through? I believe not. All of us are given the skill of being empathic to understand what they're going through. And that's why, as a researcher, it's important for us to understand what our community is, so that we'll be able to relate with them and also to understand what they're going through. So that's why community-based research is also defined as going beyond the traditional researcher participant model and engages the community members as equal partners throughout the research process. And the whole goal for today's session would be emphasizing that we are, as key populations, all of us are more than a research participant. We could be a researcher. We could be a part of the decision-making process. And why is it important to include them in our approach, in our research studies? We believe that including the community-based partners will improve the outcomes of our research by achieving the relevance and responsiveness. By definition, by involving them, the community members, by involving us, community members, research becomes more relevant to their specific needs. Community engagement ensures that interventions address challenges and barriers faced by those affected by HIV. It's also important to include the community in order to increase participation. Community involvement enhances the participation of marginalized groups, such as people living with or affected by HIV, by giving them voice in the whole research process. And lastly, it will also emphasize trust and collaboration. Building trust between communities and healthcare providers and also researchers is vital. Community-based approaches foster trust by involving community members in the research design. Right? We have already had a lot of examples of community-based approaches. We know the important contribution of the community in our fight during the COVID-19 pandemic, reaching out those who had difficulties accessing HIV services during the pandemic. Community was there at the front line, linking the clients to healthcare providers. And we also have the community-based testing, which has been very, very successful. In the Philippines, CBS, or community-based screening, has been the #1 contributor of the increased testing services and capacity in our country. And lastly, advocacy and policy engagement, as I've mentioned a while ago, it's important to include the voices of the community in order to really understand what they need in order to make it more people-centered and community-based, right? Anyway, I will not be going through all of this because our speakers will be digging deeper into these principles and concepts later on. But I guess everyone already understands the importance of why community-based approaches is necessary in our endeavor, in our response in HIV care, right? And most importantly, community-based approaches in research will be anchored in the principles of equity, social justice, and respect for human rights. And that's why we always put people first. People first means improving empathic language. And we don't say infected anymore. We don't say HIV infected anymore. We always put people first by our language. And one of our speakers will also delve in deeper into that language later on. So, to introduce the speakers for today, we have the first session, the second session, and also the third session. The first session is going to be the application of community-based research framework and models. This will be delivered to us by Rainier. Rainier has been doing a lot of great job in Singapore. Dr. Rainier research broadly revolves about social determinants of health and social epidemiology. He has a special interest in the use of both quantitative and qualitative approaches to address the social and behavioral dimensions of HIV, sexually transmitted infections, and substance use. Our second speaker will help us understand more how to translate ethically, professionally, and sensitively HIV evidence into community language. We have Dr. Ben Bavington. His research focuses on studying the behavioral and epidemiological aspects of HIV prevention among gay, bisexual, and other men who have sex with men, as well as transgender women in Australia and the Asia-Pacific region. With almost 20 years of experience in HIV prevention, he has been involved in community education, policy development, capacity building, and research nationally and internationally. And our last speaker, but definitely not the least, we have Inad Rendon. Inad is he was born and raised in the Philippines, but he is now based in Thailand. He identifies himself as a gay man and openly living with HIV. He works with APACC as programs officer, and he has been with APACC since 2013. And I can't emphasize the excitement that I'm experiencing right now, and especially that I will be co-moderating with my mentor and professor, Professor Monica Ko. She is currently the Vice Dean of the Medical College in National Cheng Kung University. Dr. Ko is recognized as a Fellow of American Academy of Nursing and Senior Fellow of Higher Education Academy. She is well-known advocate for social justice and health equity and human rights advocacy for minority population in Asia. I think all of us are ready right now, but Dr. Ko will be there later on for the question and answer, and it will be an exciting part. All right, I'm gonna call on now our first presenter, guest speaker, Dr. Rainier Tan, to give his discussion.
Test. Hi everyone. Good morning. Good morning. Yeah, thanks so much, Rod, for the wonderful introduction, and thanks so much to APACC. I realize I haven't thanked APACC at all throughout all these 3 days, but it's been really amazing and so good to see everyone. Are my slides up? Not yet. Okay, great. Yeah, so I'll be talking a little bit more about community-based research, sharing a little bit about the frameworks that I'm familiar with, and its relevance in it says biomedical sciences, but broadly, I guess we do a lot of research in like clinical trials, in terms of hospital work, so I think how do we deepen engagement in these settings? And one thing that I reflect on, in my own personal experience, as someone living with HIV, person who uses drugs, gay men, like a multi-hyphenate, these kind of things are like, am I a community engaged researcher? Does it mean that me being a part of a research team, it means community engaged research? Initially when I started out, this is something that I thought was the case. But I think I came about two realizations. The first one is that like I don't represent everyone in those communities, right? Those are my own experiences. The second thing that I came to realize was that, my positionality as a researcher gave me a privileged position. I'm still a researcher after all, in spite of my other affiliations. So therefore, it's also so important to not just say that, I am part of the community. I'm doing research with the team, this community engaged research. I don't think that's the way that it works. So I think, I think really is about, how do we deepen community engagement and not just, it's no longer a matter of like yes or no. It's more like how deep can community engagement be? So, I think for the start, I'll do a little bit of definitions for community engagement, and just talk a little bit about why community engagement is so important. So, some of you might have seen this before. This is, I think, maybe one of the more prominent kind of frameworks or continua of community engagement. So in this, it's from a CTSA, a community engagement, principles of community engagement document. So it's talking about, how can we deepen community engagement? And we see it as a continuum, from outreach all the way to shared leadership. And this is characterized by increasing levels of community involvement, impact, trust, and communication flow. So when communities are involved, you can actually do a little bit of outreach, just ask for opinions, like you coexist with each other, but there's not a lot of like deep communication. But with shared leadership, as you have seen from a lot of the talks, throughout APACC, where communities get involved with the protocol development, they get involved with the healthcare, layout, the protocols. These are examples of shared leadership. We've got many good examples out there. Some of you might also have seen this Einstein's ladder of citizen participation. So this is a little bit more common in the social sciences, and we've got all the way from researcher manipulation. There's zero agency. There's no room to actually involve yourself as a member of the community or as a citizen in a research, all the way up to citizen control, where there's actually citizen power. So this is just another example that has been prominent in community engagement research. I won't belabor the point because, like throughout the whole conference, most of you would already know why community engagement and community leadership is so important. I come from a social determinants of health kind of a background. So, one thing that we also kind of promote in the social determinants of health field is that community engagement is so important, right? Because when we think about social determinants of health, we are thinking upstream. What are the things that really change structures, that change context, that lead people to more vulnerable positions? And if you involve communities, let's say someone who is sitting at the intersection of multiple minoritized identities, right? Their experiences reflect all these intersecting macro level, wickedness in the system. When you ask them about their experiences, they'll be able to tell you, these are my lived experiences. This is what I've experienced in my formative years. You're able to diagnose upstream. And when you involve them in the delivery of health services, you're able to get them to prescribe and implement downstream as well. So you actually get the whole continuum of from the start to end. It also increases dialogue between local stakeholders and also provides political support for work when you involve communities. And definitely there is power sharing as well as shared governance of health policies, as you have seen from like key population-led services and so on. In the global health setting, getting communities involved is also so important, because we are so used to thinking about, like funders funding low resource settings, or like universities from high income settings, collaborating with lower resource settings. And I think what getting communities involved in a local setting does is it advocates for local wisdom, local histories, local expertise, and local leadership in the face of such unidirectional transfers of knowledge. And it prevents what they call epistemicide. So epistemicide is the killing off of a knowledge system that might have seemed to be inferior, but actually it might actually have possessed a lot of local strength and wisdom. So these make global health practices more fair, mutually beneficial, and it helps to counteract deficit-oriented mentalities which reinforce colonial power. I won't go through this because I'm sure this is an example of community scorecards from Vietnam. It was published in the Journal of International AIDS Society. Getting communities involved basically help to improve services over time, and helps to improve health systems overall, which not just benefits communities but also healthcare professionals and providers too. Key population-led services, if you don't know about them by now, by this part of the conference, I think we aren't doing enough to talk about it. So, scoping review by George Ayala and colleagues in 2019 on community-led and peer-led services, found that there were a lot of advantages of peer-led services compared to traditional services, and that communities can effectively implement services, for their own communities. So it's very feasible. So I now draw on a few different case studies, to kind of go into the second half of my presentation. So these are some examples that, through my own work, through the work of my colleagues, we've tried to deepen community engagement through different methods. One of them is crowdsourcing. The second one would be co-creation or co-production. And the third one would be, maybe not so much community engagement, but, in our existing research methods, how can we make things more inclusive, more diverse, and, reflect the lived experiences of participants even better, and I believe that is a form of, not so much community engagement, but, community experience deepening. So with crowdsourcing, Professor Tucker and colleagues have identified a few different types of crowdsourcing activities. So these largely revolve about, one, open calls and challenge contests. So these are open calls where you ask communities out there, the public out there, to get involved in a particular research project, to submit their ideas for a particular intervention. And this way you can actually get people who are not within your own networks involved in the whole process of developing a research protocol, developing a consensus statement, and also even developing interventions. The second one would be hackathons or designathons. So these are often three-stage processes. The first stage being there's an open call for ideas. The second stage, it's characterized by intense collaborations. Sometimes it's like a 2-hour webinar. Sometimes it's a 72-hour, locked away kind of thing where you collaborate in groups. And, it ends off with an evaluation or some kind of implementation. The last one is digital systems. I've heard a few examples of crowdsourced digital systems as well. I was talking to Meng Li the other day from the Chimera D43 program, about the PrEP locator, in Malaysia. Yesterday I heard a presentation on crowdsourcing for, sexual health services for migrants in Japan. So these are all examples of crowdsourcing. Our team at University of Carolina Project China helped develop a WHO TDR practical guide on crowdsourcing for health and health research. So there are a few different steps that are sort of best practices that we have used. And through this process, we have also identified ideas and to actually develop interventions. Designathons were used to also further refine interventions, and what some past studies by Professor Tang and colleagues have found were that these are not only comparable to expert-driven interventions, but they were even more superior, to expert-driven or expert-developed marketing material for social change and behavioral change among MSM in China. The second type of way of deepening engagement, I guess, is to also, make sure that communities have a seat at the table when you are developing your protocols and developing your research material. So getting them involved right from the start. And co-creation and co-production is one way of doing that. So co-production, if you look on the pyramid on the right of the screen, at the very top of it, it really means, having researchers and communities at the same level, creating protocols together. And I think that's what's important is that it's not getting information, getting consultation, because you end up having the decision making within the research team only, but communities have an equal decision making power, with the researchers. And I think there's a lot of respect in that whole process and deliberation in that process as well. And Liesk and colleagues, do characterize this whole process in a 4-stage process. Like when you're having a research project, you need to do needs assessment for what aspect of the research project needs co-creation, plan for the co-creation activities, conduct them, and then do some evaluation. So I'm going to share one example in this project that I've been working on together with the team. So this is a project by Professor Tucker and colleagues called the Pay It Forward Gonorrhea Testing Randomized Controlled Trial, or the PIONEER study. It's an NIH R01 funded study. And Pay It Forward in short really is this social innovation to get people tested or to uptake health behaviors. First someone receives a gift, typically a health intervention such as a free gonorrhea test or chlamydia test. People feel good receiving that gift. They feel the kindness from others. They do take up the test, and then they continue to donate on to someone else. So this is the premise of Pay It Forward. And because we're trying to right now scale up Pay It Forward after a successful quasi-experimental trial and RCT, we have been working together with communities to create some of these like community engagement materials. So one of the things is that the communities aren't part of this as part of a community advisory board. They are hired as professional consultants, in co-creation groups. So they have a contract, they have terms of reference. We see them as consultants from the community, and we're working with them to generate some of these material. And I think that's a small but I think meaningful difference, right? People don't attend community advisory boards. Like they do it out of the goodness of their heart. But I feel like people still do it out of the goodness of their heart in these cases. But they have to be treated as professionals, as alongside researchers. We are all professionals. We just fill different roles based on our own training. So they've also been involved in generating protocols and workflows for our RCT as well. And this is one example, where researchers having that requisite knowledge, to bring to the table first. You would create like a skeleton, create some kind of initial framework, where we have a discussion for 1 or 2 hours about how do we get this done together. And that's something that we generate together in these co-creation group discussions. Finally, I want to talk about innovations to deepen community engagement. And I want to sort of like premise this that this doesn't really fall under technically community engagement, because community engagement would be seeing how communities can get even more involved, potentially changing structures of research projects. But what if you are in a situation where maybe you're doing some qualitative research and you want to deepen engagement in that particular project? This is also possible, and we've found several ways. So I think there's a lot of promise in asynchronous methods, methods of qualitative research that don't require everyone to be in the same room, in the same platform at the same time. There's also some hybrid and online methods as well. And what we've seen are chat-based focus group discussions and things like citizen ethnography that have helped to deepen engagement, both I guess at the project level and at the study level as well. So we've done some chat-based focus group discussions using WhatsApp, using a WeChat. These typically happen over the course of like 5 days. Like a focus group is 5-day focus group. And we have a set of questions for each day. We have a topic for each day, and we allow individuals to respond when they can across 5 days. And what this does is actually a lot of low costs for researchers. We found that it was a lot more accessible and person-centered. So in a study using WeChat in China, about 60% of our participants who identify as men who have sex with men, reported that they had never attended an in-person LGBTQ-related activity before. And it makes us wonder, for these individuals participating in this focus group discussion, would they have attended something in person that might have, like inadvertently exposed their sexual orientation to other people? Third, it also helped to democratize participation. So in these chat-based focus groups, it's not just directed by a facilitator, but everyone can share snippets of their own life. You can share videos, you can share pictures, you can share links, anytime you want. The dynamics are a lot flatter in that sense. Then we covered a wider breadth of topics. Although what I would say is that, we do compromise a little bit on depth, and there are some papers that talk about that, which I won't go into detail. Okay, second last slide. I think I'm gonna try and make it for time. So like citizen ethnography, I just want to introduce this framework. So there is a paper out there on doing scaled public citizen-led research that I found really impactful. It teaches you how to get more people involved. In research, including lay, public, and community members who might not have had previous training in research. So do check it out. It's by Amiruddin, Harrigan, and Naqvi, whom Iqbal Naqvi was my mentor back at the Singapore Management University in sociology, and that's where my love for community engagement started as well. And I also want to do a shout out, in terms of citizen ethnography. If you are doing qualitative research, you don't necessarily only need a researcher to guide qualitative research, but if you give participants a chance to do photo voice, take photos and interpret these photos by themselves, you can do it and create a lot of meaningful insight as well. And I think that's one way of deepening the kind of insight into the lived experiences of participants too. And I believe the team doing this is also here today. I see Pui Lee, I see many colleagues from Malaysia too. And of course, Valerie Anshaw is one of my idols from research. But yeah, I hope that was helpful, and thank you so much, Rod, for the opportunity.
Let's now call on Dr. Ben for the second session.
Thanks very much, Rod, and good morning to everyone. It's really lovely to see you all here so early on a Saturday morning, so congratulations for making it. Just wait for my slides. Thanks. Okay, good. Okay, cool. So I'm going to be here talking a little bit about translating HIV evidence into community language. There's really two focuses of this short presentation, which is about good practice in presenting community-based research findings to the community before and after publication. I'm not focusing too much on that one because Rod really wanted me to focus on the second one more, which is about identifying and revising potentially stigmatizing terms in writing research manuscripts for publication. So let's just get right into it. This is just 2 slides. So I don't think I have to tell anyone here, as Raina has just so clearly outlined, the importance of community involvement in research should be from the very beginning right through to the very end. But what I've sometimes seen that even in some of the most well-designed community projects that involve community members in the development and production of the research, sometimes it stops there, and then the researchers get the data and kind of hoard the data, start writing it up, doing their own analysis, and then and go from there and only publish in academic journals. It's really good practice to involve community before publishing your research results. So actually taking your results back to the community, validating them in a way to check, are you agreeing with the interpretations that we're bringing to these data? To make sure you use the most appropriate terminology. Like I said, you validate the interpretation and you notice things. The community members might notice things that the researchers might not see in the data. Of course, what you do and how you will do it will depend on how the research project has been structured from the beginning. And again, Raina pointed out some of the different styles or levels of community-based research that can happen. Best practice would be to have community intimately involved at all stages, and this can include at the very end when you're interpreting the findings of the research. One thing that we do a lot in our setting in Australia, but also around the region, is we present our preliminary findings to community organisations before we publish. So before we even do any public reports or anything, we take it to these meetings, almost like a focus group discussion to say, are we finding what we think we've found? And I think that's been really, really helpful. Another really good thing to do is invite community organisations and staff members to be co-authors on abstracts for publication. So with almost all of the studies that I run, we would do this. We'd go to some of the key community organisations in our setting and we'd ask at least 1 or 2 people to come onto the papers with us. After publication, it's really important to disseminate research for it to be used in policy and practice. A lot of research just gets put up on an academic journal behind a paywall. It's hardly read by anybody, it's hardly cited by anybody. And so it's really important for research to be seen so that it can be engaged with and used. And dissemination of research should go beyond other researchers and include policymakers, clinicians, community organisations and community members. As I said, journal articles are often not accessible, so it's good to try to share those articles and the content within those articles in a more accessible way for community members and community organisations. So again, another thing that we do quite a lot in our setting is we might finish off a research project, have a public-facing report, and then go to the community organisations that we work with and actually present those findings. That means that they've got a PowerPoint presentation they can use that's really accessible, it's in lay language, and then they can actually take that into their work and use it in their work. The other thing that we do quite a lot in our setting is that researchers can work with community organisations to ensure that their findings are presented in non-expert language. So one of the best ways to do this would be in infographics. So sometimes we come up with really complicated epidemiological data that comes out of a study, for example, the opposite attract study that was run on treatment as prevention. And we went to the community organisations and said, can you turn this into a really easy to read and understand infographic that we can put, all of us can put all over Facebook so that everyone can now understand that treatment does prevent transmission. It's a really effective way of going. Right, I've got about 11 minutes now to talk about stigmatising language, which is really what Rod wanted me to focus on here. So I think we all know by Saturday of this conference what stigma is. So it's the actual or perceived shame or disgrace that sets a person apart from others based on an attribute that the person possesses. And there are obviously different types of stigmas. So you can have internalised stigma, you can have enacted stigma, which is actual experiences of stigma, and then there can be anticipated stigma where you're fearing what stigma might happen. And as we know in the HIV space, there is all three of these forms that are circulating around. And anticipated stigma is often one of the things that stop people go forward for testing or for treatment. But we obviously know in this region there is also a lot of enacted stigma as well. Stigma can operate at multiple levels, from the individual right through to the structural. Now, in our area, in HIV-related stigmas, they can be related to HIV itself. So that might be things like fear of infection or contamination, all these horrible words. There can be the behaviours that are associated with HIV and HIV transmission. There can be the membership of key populations, and there can be the behaviours, characteristics and social norms that are associated with those key populations. So you can see that it can get quite complicated. It's not just one form of stigma that's operating, it's all sorts of different forms of stigma. And here, I'm not even mentioning all the other forms of intersectional stigma that might come into it too, that aren't actually about HIV or being part of a key population, such as disability, socioeconomic status, and so on. So I won't go into this in too much detail, but HIV-related stigmas of all those kinds have been shown to have many different negative impacts, including things like reduced ART adherence and viral suppression, reduced health seeking, worsened mental health, decreased quality of life, and delaying or avoiding HIV testing. That's just a few examples. There's so much literature in this area. So what are some of the principles? Rod already mentioned the first one here, which is this idea of person-first or person-centred language. So this is language that emphasises a person over their diagnosis or condition and doesn't define an individual by their diagnosis or condition. The second there is empowering or neutral language. So this is language that states things positively or neutrally, rather than negatively, or ways that imply blame or passivity. I'll go through some examples of this in a minute. The involvement in the affected populations, we've already talked about that. Preferred terminology for pretty much anything should always be informed by those living with or impacted by the condition or who are members of the relevant group. And that's really important to pay attention to because terms can change. So you might have learned a term 10 years ago and it might not be the preferred term anymore. So it's really important to stay engaged to see how the language is actually evolving. The guidelines from the US say this thing, we all know the golden rule, which is treat others how you like to be treated. Then they say, well, it should actually be the platinum rule, which is treat people how they would like to be treated. We might not understand the best ways, or we might not have that lived experience to understand how we might want to be treated. So it's really about trying to find out from those people, how do they want to be treated, and then treat them that way. And then my last one here is precision. So this is about language that is precise and clear rather than general and vague. And I'll show you some examples of what I mean. This is a great resource for anyone who's looking for just really practical guidance on what terms to avoid and what terms to use. Look this up because it's really helpful. So let's go through some of these examples. So person-first language is best for some groups. So Rod already mentioned people living with HIV. This is obviously one of the most common terms that's used now. Instead of things like HIV infected or HIV AIDS infected or even HIV positive. Now, my personal opinion would be that in some situations it is still okay to say HIV positive, but it needs to be in the right context. Generally, it's something to try to avoid, but sometimes it's okay. People who inject drugs or people who use drugs has become the common term for that particular key population. Instead of injecting drug user, which is what it used to be when I first entered this sector, or drug user. And then there's this idea of risk. So there's been a move away from characterizing particular groups as inherently risky. So people at high risk or high incidence population. They're the better terms to use rather than high risk people. You see the difference there? You're sort of saying, in one, it's saying the person is inherently risky. They're high risk in and of themselves, which is not correct. They are people who are at high risk because of maybe the situation they're in or the behaviours that they engage in. It's important to know, though, that person-first language doesn't always work. Some communities prefer identity-first language rather than person-first language. And some examples are gay and bisexual men prioritises identity, whereas men who have sex with men has been criticised in some of the literature because it erases the idea of identity and community. But again, I'll go into this later, sometimes it's okay to use MSM, but sometimes it's better to use GBM, or gay and bisexual men. And then avoiding language that disempowers people or is passive. So obviously the first point there, sex workers instead of prostitutes, that's for a range of reasons. Prostitution obviously has a lot of negative connotations, but sex workers is also more empowering because it's saying that sex work is work. So it's really putting work in the name of the group that we're talking about. It's better to use clients and participants instead of patients and research subjects. And then there's a whole range of terms that need to just be gotten rid of in the whole trans space. So it's better just to say trans men and women rather than all these outdated terms. And I am running out of time. It's important to avoid language that blames people. So hard to reach or difficult to reach is sort of saying that's your problem rather than ours. We should be changing the system to make it easier to access, not blaming you because you're difficult to reach. Again, using empowering terms, and avoiding negative ones. So drug use rather than drug abuse, has multiple sexual partners instead of promiscuous, adherence instead of compliance, and using precise or accurate terms rather than ambiguous ones. So condomless intercourse or sex should be used instead of unprotected sex or unsafe sex. We now know there are safe ways to have condomless sex because of biomedical prevention. So it's really good that we just get rid of this old term, unprotected sex, from our writing. And then sometimes in concepts, so in the whole area of treatment as prevention and U equals U, we should be being precise. We should say no risk or zero risk rather than things like effectively no risk, which is what some people still use. The word HIV elimination implies that people living with HIV need to be somehow disappear for us to end the epidemic, which is obviously not true. So we should be more precise. Elimination of HIV transmission. I'm just going to skip over those ones. To get into. So this is a more complicated one. So explanations for behaviours and outcomes can also be stigmatising. So this isn't really about the terms that are being used, it's about the explanations that are being provided by people. So sometimes the issue is not the choice of word, but it's how the author constructs their argument. And so people can have unconscious biases, but people can also purposely try to be stigmatising in their writing without looking like they are. So some common things to look out for are cherry-picking data to feed a preconceived argument, emphasising some findings over others, mistaking correlation for causation, this is a huge one, ignoring the social context and structural disadvantages and sort of making things about the individual and blame, and focusing on the shortcomings of individuals rather than systems. So let's look at some scenarios, and for each one, this was meant to be like an activity where we could actually chat because I thought it was going to be a smaller room, but we're just going to have to do this more quickly. Identifying the source of concern or the problem and then thinking how it could be done better. So for this one, the study involved 90% gay identified men, 9% bisexual men, and 1% heterosexual men, but the research is using MSM to describe this sample. So do we think this is okay? Do we think there's something better we could use? We don't really have time because we can't use the microphone, so I'll just go quickly into it. So in this particular case, it would be better to use gay and bisexual men because you can see there that all of the people involved in this study were actually gay and bisexual identified people. We're not talking here about a sample that involves a lot of men who have sex with men who are not identifying in that way. This is in a more of a Western context. I understand that in other contexts it's different. I totally get that, and I'll get onto that in a minute. This one involves 35% gay men, 20% bisexual men, 30% heterosexual men who have sex with men, and 15% transgender women. But the researcher still uses MSM. So what's wrong here? Clearly, this is a group that's made up of some people that identify with the community and some people who don't, but it also has trans women in the sample. Trans women are not the same as MSM, and this is still a mistake that's being made around the world in many, many papers. This one, the article says 50% of the HIV/AIDS infected patients caught AIDS from injecting drug use. So there's a few ones here. Clearly, we don't use HIV/AIDS infected. We don't use caught AIDS. You can't catch AIDS, you acquire HIV. And again, like as I said before, we don't really use injecting drug abuse. We might say injecting drug use in that case, to be more neutral. So the article says, we conducted qualitative interviews with 23 women who choose to engage in prostitution and were addicted to drugs. These are all real examples. I'm not saying where they come from, but these are all real examples. So in this case, again, we prefer not to use the word prostitution. Addicted to drugs is not good. You might say use drugs. And pointing out there the chose. That's really responsibilizing and individualizing and blaming. This one was a study was a cross-sectional survey and found that many socio-demographic and behavioural characteristics were associated with condomless sex. And then in the discussion section of the article, the researchers say, it was clear that alcohol use caused unsafe sex in our data, and then write a big long paragraph focused almost the entire discussion on alcohol use. Now this is this more complicated one about the stigmatizing explanations. So what's going on there? Well, they found a lot of things that were associated with condomless sex, but they chose to just focus on the one, which was alcohol use. And they're kind of blaming alcohol use. Can you notice the other problem here? They're using the word caused. In a cross-sectional survey, you can't say anything about causality, you can only say something about correlation. There's associations in the data, that doesn't mean that alcohol use caused anything. And the last one here, the article says the AIDS-infected population is difficult to find and do not come to the hospital to access treatment even though it is freely available. So you can see here with this one, the researchers or the people working in the hospital are saying, why can't they just come to us? It's just easy. But clearly it's not. If you're using terms like AIDS-infected, which is a completely outdated and inappropriate term, then maybe there's a reason why people aren't coming to your hospital. Now I've run out of time, but I will just go through some caveats. As I said before, language is always evolving, so it can take time for a new term to become broadly used. There's going to be people with different levels of knowledge and understanding, so a bit of grace and gentle correction can go a long way with this stuff. Rather than sort of fighting someone and being angry at someone, just gently correcting them, and hopefully they learn the lesson. Changes to what is preferred and what is viewed as offensive can happen really quickly. One area where a lot is happening very, very quickly at the moment is in the trans space. So we've really got to focus there on what are the most appropriate words to use, particularly in that space. There can also be disagreement within a community about what the most appropriate terms are. There are some people who really do not like the word queer in the gay and bisexual community. They hate it, they think it's offensive, and others absolutely love it. So we as researchers have sort of got to figure out what to do about that. I'm way over time. All right, let's go. So sometimes there are just some constraints. There's word limit constraints. There are some other things that make it difficult for people to use words in the right way. Obviously, preferred terminology is language specific. So I've been talking about English language here today. Most published research in academia is in English, but some concepts and terms in English don't translate well into other languages or vice versa. Some concepts can be translated into other languages, but the translated term won't actually make any sense to anybody in the target language. So some decisions sometimes have to be made about balancing comprehension versus using the most preferred term. And it's also just important, last point, to note that people who speak English as a second language may not always be completely up to speed on the most appropriate words to use within the English language. And so again here I just say native English speakers should be aware of their privilege, and a bit of gentle correction and a bit of grace can go a long way here rather than getting angry. So I'll leave it there. Thanks very much for the opportunity to speak.
Inad to have a call for action for a deeper collaboration between researchers and the community. Inad?
Hi, thank you. I'm just going, I don't have a slide. I'm just scaring you. I don't have slides. I guess the panelist members have already mentioned what are the things that we can do to engage communities much more effectively and efficiently. But for me, my engagements in the previous year's conferences led me to some reflection. The global HIV agenda and its actors, that includes me, have become driven by data. Although we take different approaches in addressing HIV, these approaches share one common aspect. They are directed by the strategies set by the global standards. We experience a shift of priorities into reaching globally accepted goals defined exclusively by numbers. We operate in an era where achievement of high targets is celebrated as a successful HIV response. In our engagements, most often than not, we forget and we oversee the fact that we are also humans and not numbers. I am a person living with HIV. How does that make you see me? How does that impact your view of me? I am a member of the community, of course. Am I someone different from you because you are scientists, medical professionals, or academics? Or am I different because I am a person living as a virus who can be a potential subject of your research? My name is Inad. I'm a person living with HIV, and I'm going to say this not because I wanted to show off, but because I wanted to make a point. I'm also a lawyer. I worked in a legal realm in the Philippines for 3 years before I worked in the HIV field. I am an amateur entrepreneur. I had a small bakery. I'm also a baker. I am an artist. I had one art exhibit a few years back, and I'm going to have my second exhibit this year. Speaking on behalf of other people living with HIV, we are more than just a virus. Sorry. And I am having this call to action not because we wanted to be part of the research community, but because we wanted to be respected and we wanted to be involved and also own the data that we have lived for the past few years. First, we have to promote PLHIV ownership, or we have to promote key population ownership in these studies. Community, the word community does not mean no capacity. And I have just made that point earlier. We have to see people living with HIV and key populations as equally able partner in the medical, scientific, or academic endeavors. So when I say, so Rod has already defined what a community is earlier, but for me, what is a community? Community for me is the group of people or group of people who are living with HIV who share the same lived experiences of stigma, discrimination, human rights violation, challenges in accessing antiretroviral therapy, challenges in accessing or transitioning from nevirapine to dolutegravir, challenges in accessing viral load testing, challenges in making sure that we have stigma-free and discrimination-free experiences in the medical setting. So when I say that I am part of the community, I say that I am part of this group of people who have shared these lived experiences. I am not just a person living with HIV, I have shared these experiences. I am also entering into a new business venture. That's not an important fact, but the thing is, I am looking for professionals who are also living with HIV. I call them professionals instead of people living with HIV experts, because it is high time now to drop the label PLHIV and just say professionals. And I am surprised that there are a lot of professionals out there who are financial advisors, lawyers like me, doctors, insurers, and media and communication experts. And we don't see them anywhere. Why? Because this now goes to my second point, where we are calling for the researchers to observe empathy, not for the sake of complying the ethical standards, but by actually observing what we mean empathy. Finding out our HIV status, we are most likely to lose or leave our jobs. for various reasons. Learning about our HIV diagnosis, we cope from self-stigma. We struggle to accept our new identity. This impacts our decision-making of whether to continue with our studies, to continue with our jobs, or to look for other jobs that accepts us because we have this preconceived notion that we are not accepted anywhere. If we're having difficulty looking for equally able people living with HIV, it doesn't mean that they don't exist. Evidence of absence is absence of evidence does not mean evidence of absence, and I think that's very much an accepted principle in research and scientific community. The third one, we have to go beyond the medical and the clinical subject matter and include the quality of life. The sets of information that I've just shared support the realization that we should be strongly advocating for the inclusion of mental health or quality of life of people living with HIV in our indicators or in our research studies. And lastly, in relation to community ownership, for the past few days, so I have been here in Singapore since the pre-APACC meeting which started last Monday. And every time I hear about presentations which refer to PLHIVs or communities, it's always them, they, he, she, him. I have rarely heard us, we, or I. Why is that? Even if I am a person living with HIV presenting here, I still use they or them. And why is that? I don't know the answer, but help me. So the academic, medical, and scientific researches, we view them as a pivotal moment that can change our lives. For the past few years, this has been true, but only to some. And I hope moving forward, we can try to make this true to everyone. Thank you very much.
Thank you so much, Sinead. That's a very, very powerful call for action. Now, I'm going to give the microphone to my professor and my mentor, Professor Monica, to start with the question and answer. And I also encourage everyone online and here in person. We are a room full of people. We don't have enough spaces right now. So thank you for coming here. Right, this is a jam-packed event right now. So I'm gonna give Professor Monica the microphone. Go ahead, Professor.
Because we only have 5 minutes left. Yeah, so I open to floor. If you have any question, please raise your hand. And before you thinking about your question, I would like to ask a question for 2 aspects. The first aspect is from the researcher for Ben and Rainer. Yeah. So. From your perspective, do you think what is the key benefit and what could be the challenge to working with community or organization? Okay, so that is and how that implement in the policy making. And for the community worker, my question is, what is the challenge to working with researchers, especially for the medical authorities? Yeah, and how do you put your idea or work with them on policy making? Okay. Anyone want to? Yeah. Okay.
I'll start first, and I'll make it really quick. So the benefits, I think we've covered a little bit, but I wanted to touch on one challenge that I didn't manage to talk about, and I think it's the structural systems that we're in, the healthcare systems, the research system, like when we think about research grants, is there, institutions like universities protect themselves, they have 20%, 30% indirect cost overheads, but are we paying the same overheads to like community groups when we engage them as collaborators? I know some community groups in Singapore say that when you collaborate with us, 20% of your grant needs to come to us as a service fee. And I think that's a good practice. So things like that structurally, I think will help a lot. But there are challenges in doing these things still.
I said, yeah.
Yeah, I was going to say something really similar about it's slightly different. That's a really pragmatic point. But one thing a challenge we come across is the capacity. So it's generally okay in areas, say, like gay and bisexual men are a pretty well-organized community. Sex workers have been a pretty well-organized community. But there are some emerging communities that have not received the funding from government or philanthropy. They're much more nascent. And what we're finding is if we try to work with those community groups, it's really just about capacity. They don't have funding. They don't have people. They're not a professionalised workforce like some of the other groups are. So some of the groups I'm talking about here would be these nascent trans groups that are coming through. They usually have no funding at all. In our context in Australia, there's a really big movement starting to happen in bisexual and pansexual identifying people who are saying, hang on, we've been left out of all of this for 40 years of the epidemic and we want to be part of it. But all those organisations, the bisexual organisations around Australia, for example, are all grassroots. They have no funding whatsoever. So when we start to invite them to be on committees, be part of research projects, invite them to comment on surveys, that's actually a lot of effort and work. And of course, we try to pay them where you can, but often these research projects are run for very, very tiny budgets, and so there's not a lot that we can actually give them either. So it becomes this kind of circular problem of capacity and funding.
Okay, excellent. Yeah.
Yeah, hello. So one of the challenges, I guess, reflecting to what Rainer and Ben has mentioned, one of the challenges actually first is the quote-unquote the operational capacity, not the individual capacity. Operational capacity to engage with researchers because we don't get much that support to operate on the research component. And second, because of that, there are so speaking on my experience, last-minute invitations to be part of this advisory boards.
Yeah. Okay, so the structural problem and also the investment, yeah, that is important. Not invest the resources, but also investment in cultivate talent. Yeah, that is very important.
And I think it's high time, Professor, that we also encourage international funders to fund research capacity for the community, like introduction of 101 research, maybe, right?
Yeah.
Anyway. Do we have
only have 30 seconds. So any question? No, only one question. Please.
We have 2 minutes, Professor. Yeah.
No, only. Okay, so one question. So where is the question?
Hello, my name is Henry from Malaysia.
Okay.
My question is, in your respective community context, what is the best mode of delivery of in disseminating your research ideas or result to your community using very layman and understandable languages? Any tips on doing this in whether it's a forum or group that telling the community that your research outcome is such and such? Yeah, thank you.
Okay.
To make it quick, I think in my experience, we've done town halls. So, in terms of dissemination, sometimes the results can be sensitive. It can be interpreted in different ways. Getting the communities involved in how we want to disseminate it. Even thinking about whether we should publish it in a journal or whether it's a high impact journal, lower impact journal. Sometimes we've got to make compromises on the academic end of things. Maybe in return for political impact. Some things like that I think are important to consider as well.
Yeah. I think it really depends on the context and what the research topic is, what the community is you're working with, and so on. I know that sounds like a naff answer, but it's really true. So sometimes it's possible to do something like a big town hall. I think what's required for those kinds of events would be a fairly well-empowered community where people are actually willing to come forward into a public space, potentially identify themselves in a particular way to hear from the researchers. So where you've got a empowered community like that, it's a great way to do it. We've also done much smaller things, like very small focus groups, or something that's done online, where we feed back the information in a way that people can have their cameras off. So it's still like a focus group discussion, but they're not revealing who they are. For some topics, like I said, you can do things like infographics. You can really kind of try to make sure that community-facing information is really in lay language. So it's trying to get rid of all the expert jargon out of things so that people can really understand what they're hearing. So there's just a few points there.
Last, I think it's important for us to be able to summarize the findings with their partnership so that we can ensure that what we have written is accurate for better understanding. Thank you.
Yeah. I wish we have longer time for a Q&A, but I would encourage everybody from the audience to just approach our guest speakers and then ask directly to them after this session, right? So before we close down, I would just like to announce to everyone that there will be a survey, an online survey to be given to everyone. Please fill it up at the end of the day. And we have upcoming parallel session that are about to start in a few minutes. We have plenary session on implementation science, which will be held here in the same room. And we also have a plenary session on hepatitis B and HPV and the intersection of infectious diseases and cancer, which will be held in room 324 and 325 as a breakout session. Thank you so much for everyone's active involvement and active listening, and we look forward to meeting you in the next APACC. Thank you so much. And thank you so much to our guest speaker.